Now we're going to talk a little bit about strabismus surgery, and some patients are so worried when we talk about surgery, because actually most of the cases are regarding young children, and parents freak out when they can hear that their children are going through a surgery. So the question here is, does every squinting child need to go through surgery?
No. In fact, we have seen that the number of children that need surgery today, since we refract them earlier and we treat them better, is reducing over time. And we have on the other side many more adults that have acquired strabismus. So when I began, the number of adult strabismus was very small, and the number of children needing surgery was very large. So no, first I have to say that we have to begin with glasses and to repeat the refraction, because sometimes you think you gave the proper glasses and the children still have more refraction, and many of them improve with glasses. Then some children, when we are treating them amblyopia with a patch, they begin to see a little bit better, they begin to fuse, and they go out from the squint. So sometimes, although the patch in the 90% of the cases is used to control the lazy eye, the amblyopia, it's also used to make them fuse. So there are certain strabismus that with the patch improve. Some have been treated with sectors, that is small, two tiny tapes, in order that they improve the abduction, and they improve also with these techniques. Some others, I use prism in acquired cases. It's not very frequent, but also can be improved. Some use visual therapy, which there are sensorial treatments that they can be efficient in a small amount of patients, and if they are treated with visual therapy, they can have to be controlled by the ophthalmologist in order to see that they don't have secondary effects of the visual therapy. So, and finally, others go for Botox. We have a certain children that they can be treated with Botox, and a certain amount will need surgery once we have seen that all those phases are passed and they don't need it. Of course, there are certain cases that from day one, we know that's going to be surgical. And maybe your doctor will tell you, we are going to try the patch and the glasses, but for sure, this child is going to need surgery.
Yeah, it's just about finalizing the definite angle of strabismus in order to make sure that we are addressing the right angle, not to overcorrect or undercorrect.
Of course. And to have several times that you have measured that the child has always the same amount of strabismus.
Okay, there is another question that we are asked by the mothers, actually. Can we delay the surgery? I mean, okay, my child is squinting and I know that he is squinting and I know that he's going to need a surgery, but can we delay a surgery for a while? So what are the complications, or what are, let's not say complication, what are the drawbacks of delaying a strabismus surgery if a child needs a surgery right now?
Well, when you have a child that has a squint since childhood, and he was born with the eyes squinting, if we align them, they can have a little bit of fusion, and maybe they can be more stable. But the doctor will tell you, depending on many factors, how this possibility is. If you have only an horizontal squint and you place the eyes straight, maybe he will fuse a little bit and he will improve. If you have a very complicated squint with verticals, the capacity to fuse is going to be smaller, so there's no need to rush until the doctor has stable angle to go for surgery with all together. If you have an acquired case, let's say a child that he is aligned and suddenly he has a squint. Well, he has been using his eyes, fusing, and then when he squint, every eye begins to go in one side. And if you can operate it as soon as possible in a certain way, maybe the child will have much better binocularity. But there are cases in which the doctor knows that there are some unpredicted factors that, yes, you may operate him, but he's not stable. And if you operate it too soon, he's going to have many more surgeries. So what you have to hear to the doctor, the benefit of trying to obtain binocularity against the risk of having more surgeries. And there are other cases that we wait and it is not a problem. And even operating them later on, we have binocularity. So I think one have to trust the doctor to say, we are going to operate him because we want to have binocularity, which is the risk of waiting in my certain case.
Yeah, this is a great advice. Actually, we have to advise the patient that they have to, once you are visiting a doctor, you have to trust his decision that it's the best of the child. Mm-hmm. Right. So does the child's refraction affects the surgical dose? I mean, does his refraction, whether he's a high myopic or a hypermetropic, affect the surgical dose? We can increase the amount of the surgical dose or decrease it according to his refraction?
Yes, for sure. I'm going to try to make it easy. An hyperopic child, which is frequent in children that they have inwards squint, usually it's a small eye. And if he has more hyperopia, it is smaller. So it is, of course, understandable that a millimeter of recession in a small eye has larger impact than on a big eye. So we know, and we have tables, how to reduce the amount of surgery depending on how big or how small is the eye. On the opposite side, a large eye, that's a myopic eye, a millimeter has less impact. And they are muscle that they are more fibrotic. So yes, for sure. And there are other factors. For instance, small eye, hyperopic, when he's bigger, the tonus releases, and sometimes we can have overcorrection. So we have to be prudent with the amount of surgery. And sometimes if we have a residual strabismus, we prefer to wait until we do the next surgery. While if we have a large eye, very large eyes may be complicated. They may have small scleras, and we can perforate more. So there are things that ophthalmologists know, but of course, your strabismus is not the same of your neighbor's strabismus because we have very different things.
Yeah, that's very.
So that's why maybe they won't understand. Well, my child has been operated and yours no. For instance, my child is operated from age 1, and mine still with the glasses. When he takes off the glasses, he's still squinting. It's a completely different situation.
Every child is a peculiar case. They're not the same. They are not machines. They are human beings with tissues that differs from one to the other, you know. Okay, another important question which is frequently asked by the mothers before going into a strabismus surgery. It's always about recurrence. Will the squint come back again? If I perform a surgery now, will the squint come back again? And if it will, why would I do the surgery?
Well, strabismus, I always tell to my patients, is like a room full of folders. The in squint, the out, the verticals, and then we have folders in which depend the refraction, in which not, with plus vertical or not. So there are many differences. We have squints that we have good results until the 95% of the cases, and we have others in which, unfortunately, we have 50% of results. So in certain cases, we can tell them that, for instance, sudden acquired strabismus, that we align them, we can tell them that it's very rare that it's going to destabilize over time, while we have others, intermittent exotropias, that they may recover over time. But so if your doctor tells you for sure not, it's very difficult. But what it is important to say, it is well worth to operate the child at this moment. And if you have, let's say, a child, boy or girl, not a girl, boy or girl, that they are going to school at age 5, until they'll get married, in case it recovers, in case it recurs. No, once we have a squint that is stable, that it says it's not going to improve, we have to go for surgery. And 80% of our cases need one surgery in life. And some others, unfortunately, they will need more. But it is your doctor, the one who will suggest which is the advantages, which is the disadvantages, because the doctor wants the best for the child.
And actually, we can't stress enough that strabismus surgery is not only a surgery to improve the appearance of a child, it's also regarding the function of the eye, his visual performance, his fusion, his binocular single vision. So it's about the function of the eye as well as the appearance of it.
I have to tell you one thing. I've operated 3 ophthalmologists with squint, that they had squint, but they had difficulties with the microscope. And once they were operated, they could operate well. So for sure, it's much more than appearance.
Right. So in case of recurrence, if the child goes into a surgery and then, God forbids, the recurrence occur, would you advise the surgeon to take it slow in order to find the stable angle? Because some parents, he's under the stress of the parents telling him, my child hasn't improved, I don't think this is the right results. So sometimes surgeons rush into a second surgery. Do you think this is the right decision?
Well, that is something that we have feel, all of us, patients that force us to take decisions that we are not convinced. And sometimes we cannot transmit with enough clearance why they have to wait or why we have to rush. But what it is important is that sometimes the patient tell me, no, I don't want that. And I always ask, which is your profession? And one of them, he told me, I'm a lawyer. And I told him, well, what I can do is to follow you or not to follow you, but I'm not going to be able to discuss what is good for the child. So if you are not convinced of the doctor, take another position. But if your doctor tells not to go for surgery and the next one tells you yes, be aware, because maybe the one who say no is the one who is clear.
Right.
Because the second is telling what you want to hear.
Right, that's true.
So the most important thing is to try to trust the doctor. I mean, to have a doctor that you feel he's a good professional. And
I think a proper preoperative consultation and discussion with the parents about the consequences will help a lot in order to anticipate what might or might not happen. So it will make them more relieved when it might happen.
When I have those patients, often I tell them, I want to wait because that and that, because I think it's going to improve by its own. And then if we reoperate it now, we will need to undo it afterwards. Right. But if you're not sure of my opinion, please tell me. I will tell you another good doctor that will tell you. But don't select anyone that will tell you whatever you want to hear.